Hereby, I open this academic ceremony in which Marta Abdulai will defend her academic thesis, Individual and Environmental Determinants of Adherence to Antiretroviral Therapy Among People Living with HIV in Ghana. Candidate, may I invite you to present a summary of your study and your conclusions?
Thank you. Dear Pro-Rector, highly esteemed opponent, family, friends, both here and online. In the next 15 minutes, with great pleasure, I present on my PhD thesis on the individual and environmental determinants of adherence to antiretroviral therapy among people living with HIV in Ghana. HIV remains a public health problem, despite the availability of antiretroviral therapy. And across the world's population, 38.4 million people are living with HIV, and about 70% of them live in sub-Saharan Africa. Ghana is a country in West Africa with a population of 31 million and an HIV prevalence of 1.7%. And so without continued efforts, the incidence of HIV cases would continue to increase. Ghana is a signatory to the United Nations Global Goals 95-95, and it targets that by 2030, 95% of people living with HIV should know their status, and 95% of those who know their status should be sustained on antiretroviral therapy. And out of those on antiretroviral therapy, 95% of them should have reached viral suppression. And if patients reach viral suppression, their CD4 cells will be regenerated, and this will boost their immunity, reduce opportunistic infections, and improve their overall quality of life. Globally, 73% of people living with HIV are on antiretroviral therapy. And so adherence is very important for HIV prevention, treatment, and viral suppression. Osterberg and colleagues define adherence as the extent to which patients take their medications as prescribed by their healthcare providers. And so any deviation from the healthcare provider's prescription is suboptimal adherence, and suboptimal adherence has their consequences on the health of people living with HIV. And so, to tackle the problem of non-adherence, I, in the past few years, examined the individual and environmental determinants of antiretroviral adherence among people living with HIV. How did I do this? I employed sequential mixed methods approach. First, qualitative interviews and focus group discussions. These were followed by a longitudinal prospective survey. So I present on 5 empirical studies of this dissertation. The first study was a qualitative inquiry among people living with HIV, and I sought to understand the individual and environmental factors influencing the adherence behavior of people living with HIV. I did this by conducting 20 in-depth interviews and 3 focus group discussions. The findings revealed that people living with HIV usually compared their health status prior to taking the medication to after they took the medication. And it was clear that their visible improvement in their health was a motivation for them to continue to take their medication. The anticipation of stigma at the healthcare facilities was a challenge for them to visit the clinic for their medication refills. Again, the fact that people living with HIV psychologically adjusted to their condition by comparing it with other chronic conditions like hypertension or diabetes shows their resilience. They normally, in this study, self-regulated by using memory cues. They also self-regulated by disguising their medication bottles to avoid any stigma. On the environmental side, the cost of transportation was a huge challenge to medication adherence because they found it difficult to get money to go to the facilities. However, the medication was free of cost to the patient, but the transportation to get there was a challenge. The attitude of healthcare providers, according to persons living with HIV, was cordial, and this was rather reassuring to know. In their words, the healthcare providers were friendly and took good care of them. So in furtherance of the cordial relationship that healthcare providers have with the people living with HIV, in the second and third studies, I explored further individual and environmental factors that influence the healthcare providers' behavior towards people living with HIV. And this I did by conducting 33 in-depth interviews among healthcare providers. The findings indicate that healthcare providers could get angry with people living with HIV. They could also express emotions like pity, sadness, based on their perception of how people living with HIV got infected. So this would be in a case of a commercial sex worker, for instance. If the healthcare worker perceived that they got infected through non-violating behavior, they will respond with anger, which is an emotion they express towards people living with HIV. The knowledge about HIV and its transmission also influence their behavior, the behavior of healthcare providers towards people living with HIV. Supervisor support was revealed to be minimal, and the availability of logistics was also one of the things that actually spoke to the way they behave towards people living with HIV. In their own words, they will ration basic logistics like gloves and use it on people who they know are HIV positive. But if they were not sure the person's status, it was okay not to use a basic logistic like glove. And this creates some kind of tension between the healthcare provider and the person living with HIV. The training on HIV also was one of the factors that influenced their behavior towards people living with HIV. In the first study, I looked at the stakeholders' perspective on the factors influencing the implementation of antiretroviral therapy adherence. And this I did by conducting 15 in-depth interviews. The findings indicate that the policy stakeholders were generally satisfied with the policy implementation, and they felt that the policy was clear, it was simple and easy to follow, and ensured uniformity across all the facilities that provides services for antiretroviral therapy. They would usually receive some form of training on new policies that come to help with the implementation. They were mostly aware of the current policy used for treatment of people living with HIV. And it was quite surprising that one of them referred to the old policy of starting medication on CD4 count. Monitoring of the implementation of the adherence policy to ensure the fidelity of its implementation in the facility was minimal, as reported by the stakeholders. Again, the fact that people living with HIV have to live on lifelong medication was a challenge, and they would usually look for cure. And people who provide alternate sources of care would tell them or profess cure for HIV, and some of these things make them fall prey to these alternate sources of care like the faith healers or traditional or herbalists to get cure and not take their medication for the rest of their lives as they have been advised in the facility. The fifth and final study was on the determinants of medication adherence intention and behavior among people living with HIV. This was a follow-up study among 750 people living with HIV. We followed them for 6 months, and there are some psychosocial factors that were identified in the first qualitative inquiry, in addition to literature and some theory, informed the factors that we explored in this study. And we sought to examine the factors or assess the relative importance of these factors that we found in the first study on the adherence behavior and also on intention. The intention to adhere to adherence, to adhere to antiretrovirals were perceived behavioral control, outcome expectancy, resilience, and age 55 years above. These factors explained the intention to adhere to antiretrovirals. However, the actual behavior was influenced only by self-regulation. So in conclusion, outcome expectancy, resilience, anticipated stigma, and self-regulation influence the adherence behavior of people living with HIV. However, self-regulation remains very critical in any adherence intervention in this study. And we suggest that educational programs that optimizes self-regulation strategies and also strengthens feelings of outcome expectancy, resilience, should be beneficial for antiretroviral adherence. Additionally, the important role of healthcare providers, partners, family and community members cannot be overemphasized and requires the needed attention, given the important role they play in the adherence behavior of people living with HIV. And so interventions that improve social interaction, HIV knowledge and awareness would be useful. Thank you very much, and I give the work back to the prorector.
Thank you. The opposition will be opened by the chair of the assessment committee, Professor Fred Zijlstra, and he is professor of work and organizational psychology at this university. Professor Zijlstra.
Thank you. Dear candidate, let me start with complimenting you with your work. You have made a very interesting and relevant study and dissertation. I can see how important this is in the community of Ghana and the population over there. However, I'm not only here to compliment you, but also to ask questions. First, I have a methodological question. You have just outlined in your presentation that you have conducted a number of qualitative studies, interviews and focus groups with individuals, but also with professionals. And I was wondering, in particular with the professionals, you have been trying to find out whether there are stereotypes, cognitive biases, and so on and so on. Whether interviews and focus groups might be the most appropriate method to detect these kind of biases. In particularly because, well, biases are sometimes also that people are not aware of them themselves. In addition, how can you be so sure that the biases, the cognitive biases and stereotypes of the healthcare providers, the professionals, and the interviewers do not play a role in interpreting the results? Yeah?
Thank you very much, highly esteemed opponent, for your compliments and also for the question. Indeed, the qualitative interviews that we conducted gives insights on the stigmatizing. It gives insights on the behavior of healthcare providers towards the people living with HIV. And we used qualitative methods to get these experiences from the healthcare providers themselves. I believe that the qualitative methods that we use were able to get these experiences from the healthcare providers. And in ensuring the rigor of the findings, To ensure that we get the rigor of these qualitative findings, we applied the correct checklist to the data that we had.
Sorry, say again, what did you apply? The
correct?
The correct?
Correct checklist. That speaks to the rigor of the qualitative interview so that the biases in terms of interpretation will be reduced. So the first one will be issues around confirmability, whether the findings that we got from the healthcare providers sharing their experiences in this stigmatizing behavior influences their actual behavior. And so confirming the interviews that we did against the audio recordings to know that indeed what they are saying is what we are interpreting. And also keeping field notes during the interviews also help to confirm what they said against how we are interpreting this. The other measure of rigor for the qualitative interviews is the transferability. We are able to, in this work, I have been able to describe the settings within which these interviews were conducted. And so the findings of this study could be transferred to other settings based on the experiences shared from these healthcare providers. Issues about dependability also comes in terms of ensuring the rigor of qualitative interviews, so that based on the analysis and a detailed description of the methods that are used in conducting this interview, we are able to know that the findings from the healthcare providers vis-a-vis its interpretations are quite dependable.
Okay, I understand that you have been quite rigorous in making sure that what you have heard and found in interviews is also transferred to the results. Mm-hmm. However, my second question is still open. Mm-hmm. I mean, how can you be sure, and what did you do to ensure that, for instance, the cognitive biases and stereotypes and beliefs of the interviewers, the researchers, did not trickle down into the results? I mean, are you aware of any method that could avoid this, and how this generally can be done?
How the cognitive biases of the interviewers.
The researchers, yeah, the interviewers and the researchers themselves.
Great. So as also one of the issues of reporting the rigorousness of the qualitative interviews, the credentials of the interviewers were also stated. So an expertise in qualitative research that kind of takes out your own biases, the credentials, the fact that you have done these qualitative interviews and you have the experience. And then in the course of interpretation of these qualitative findings, I ensure that comparing what they have said with actually what is in the audio recordings, so that my own feelings or biases about whatever is being discussed does not influence what is being reported in the thesis.
Yeah, and generally the interviewers and researchers also discuss amongst themselves what kind of potential bias or what kind of ideas they have regarding the subject, the topic.
Sure.
And is this also something that you have done in your group?
Sure. So in terms of, so we do a lot of debriefing after the qualitative interviews, and also there's intercoder. More than one person codes these transcripts. So more than one person codes the transcripts that we use for our discussions on these subjects, so that it is not the subjective opinion of just one person, but then it includes the opinions of other researchers. And then where there are points of divergence, we discuss it until we reached an understanding of what the real issues are. Yeah.
Okay, thank you very much.
The opposition will be continued by Dr. Biden, Associate Professor in Epidemiology and Biostatistics at the University of Health and Allied Sciences in Ghana.
So I've enjoyed listening to you, candidate, and I'm pleased about the progress you've made. I have a question. You indicated that self-regulation strategies are the approaches that you would recommend. Now, I would want you to break it down in terms of the Ghana Health Service and the National AIDS Control Program using your results. What specifically do you expect them to take from your study in terms of enhancing patient self-regulation in order to promote adherence?
Thank you, highly esteemed opponent, for your compliment and also for your question. Self-regulation was identified as critical for the adherence behavior of people living with HIV. And as the 95-95 goals that I elaborated on expects that the person living with HIV would be on sustained medication, and then their sustenance or adherence on the antiretroviral medication will lead to the viral suppression. And so at the policy level, the role of the person living with HIV and their ability to self-regulate their medication is very important. It gives them, it makes them take the personal responsibility of taking their medication when they have to take their medication. And from the findings of our study, we saw that they try to do that by disguising the bottles so that other people will not know that they are taking the antiretroviral medication. So stigma might be a problem for them, but they try to find ways of going around stigma to take their medication. So they will disguise the bottle and then take their medication anyway. Sometimes in our study, we have also noted that the people living with HIV also time their medications according to their wake up or sleep time. And so all these factors could be taken into counseling program at the various facilities so that the people living with HIV can be encouraged that even in the face of stigma or in the face of non-disclosure, they are still able to find ways of taking their medication. And this is very critical, given that now, as per the policy, people living with HIV do not need a treatment support. So there's a lot of responsibility on them as people living with HIV. And so this responsibility on them is very important to consider in counseling persons living with HIV at the various healthcare facilities. So what the Ghana Health Service actually can take from this is to include issues about self-regulation in the counseling processes, either a post-test for all people who test positive and have to start immediately on medication as the policy requires now.
Yes, thank you very much. I will make a follow-up on that. So that is quite a change from how we have approached this in the past. In the past, we've tried to encourage patients that do not lose your self-esteem, be bold, be able to let people know you have HIV. If you are taking medication, there's nothing wrong with it. And yet we have not succeeded, or we haven't quite succeeded. As you have found out, people are still finding ways to. Are you advocating that the program begins to identify with the exact ways in which patients begin to self-regulate, the kind of practices like hiding their medication, perhaps would you even go far to say hiding their status, such that they can, it will enhance their adherence? We have an exchange here.
Yes. Relation to whether they hide their medication or not hide their medication, I believe that the important thing for us and also for the policy is for people living with HIV to take their medications. And also, once they take their medication, it increases their overall health and well-being, and it improves their quality of life. Again, it reduces the transmission of the virus. And so it fits directly into the policy and the targets we wish to achieve. We are not by any means saying that people living with HIV should hide themselves. But for those who are not able to disclose, as it were in the study that we identified, that people will rather keep it to themselves. And in the words of one of the people living with HIV, it's my health, it's my problem. And so if the person understands that it is their health and it's their problem, and because of that, they will find ways and means to take their medication, and it's going to speak to the policy achievement, I think it's a step in the right direction.
Thank you very much. And I see the rest of my time to the chair.
The opposition will be continued by Dr. Mertens, Associate Professor in Health Promotion at Maastricht University.
Thank you. Dear candidate, first of all, also my compliments on your thesis. As has been said before, a very relevant topic. Already a few papers published, and some more to come. And also, it read really very smoothly. And that's very nice for us, of course. My question is about chapter 2, where you do qualitative interviews in people living with HIV. And you select those participants in the queuing, when they are queuing for the medication. And of course, as you say also yourself, that might be a very special group. You say that yourself in the discussion. But what also struck me in that is that there were so many females. And you addressed that as well in the discussion. And you say it's 80%, 80. And that struck me as rather a lot. And I checked a bit, indeed, what you say in the discussion about it, that there are more women in HIV care in Ghana. And I Googled a bit and saw that it is, when the information was correct, that it indeed is already a bit more of females living with HIV than males, but that's about 55% of women. And then so there is, as I understand it correctly, there are a lot of more females in HIV care in Ghana. And you give some explanations for that, but I was really wondering how it was, what it meant. First of all, you say, and I can understand that it's in part due because the prevention activities of a mother-to-child transmission, but also, and in part due to non-disclosure by females to male partners. And I really did not understand what you meant by it, because I think non-disclosure, I would have expected it the other way around or something. So first of all, could you explain a bit broader about why so many females are in care in Ghana, and also what you especially mean by this explanation?
Highly esteemed opponents, Thank you for your compliment and also for your question. Indeed, there are more females in HIV care than males. And at a point, some people were propagating that HIV was almost wearing a feminine face. And this really compares with the Ghana AIDS Commission statistics on the number of people living with HIV in care in Ghana and vis-a-vis the male and female. And it's indeed so. The people living with HIV, the females, once a woman in Ghana now, once a woman gets pregnant, she is, by virtue of the care to reduce mother-to-child transmission, expected to undertake an HIV test. And for a few of them, for some of the women, they turn positive. However, they are not able to tell their partners about their HIV status because of the consequences that might follow. For some of them, it's because they are afraid of losing their homes. And so they will not tell their male partners that when I went to the hospital today, for instance, I was tested HIV positive. They would usually not say it, according to our study and our findings. Yes. So that's what I mean by it's in part due to the fact that they do not disclose because of non-disclosure to the partners. And if they were disclosing to the partners, probably the husband could also come to the facility to get tested. And actually, that is what is usually recommended. When a woman tests positive, they would ask them to bring their partners to the facility. But because the disclosure is a challenge for them, they are unable to bring their partners to the facilities to be tested. So it will look as if more women are HIV positive because they get to be tested. However, because the males are not coming to the facility to be tested, then we don't know their HIV status.
Mm-hmm. Yeah, thank you for your very clear answer. I understand now what you mean. But that also leads a bit to the next question, because now you are addressing a population, females, who are already more undergoing therapy because are even more often detected. Mm-hmm. Also even to the people who are waiting before the clinic. Mm-hmm. And I would say the big challenge for health promotion and public health would be to get these men to even know that they are living with HIV and that they would take some action. And I would even say maybe, yeah, that's probably, I was just thinking maybe that's even the low-hanging fruit, but probably it isn't. Mm-hmm. But so that was my thought. Are you now addressing the right population? Because they are already quite willing to do something at least.
Yes. So in response to getting the males also to test, usually periodically the Ghana AIDS Commission and Ghana Health Service launches mass screenings. And so sometimes some of these males will be captured into the net. But in one of the interviews, something interesting was revealed, where a patient, one of the people living with HIV revealed that two couples had tested HIV positive from very different facilities, but none of them told the other about their condition. And both of them were hiding their medication somewhere in the house and taking it. But one night, the two of them met at that point to take their medication, and somehow, inadvertently, they disclosed their status to each other. So it's also possible that these men are captured in other programs that is attending to their needs of antiretroviral therapy. However, the women who are reporting in this study may not know about it. Thank you very much.
Okay, thank you.
The opposition will be continued by Professor Korkor Ansa, Professor of Clinical Epidemiology at the University of Health and Allied Sciences in Ghana.
Dear candidates, thank you for the very clear presentation of this very important work on adherence to ART therapy. I would like to discuss with you a bit further the limitations of your study that you highlighted. Could you please discuss whether some of the limitations you found, some of these were that the adherent people living with HIV may mostly people living would have been included in your sample more than the non-adherents, and other limitations, and then indicate whether you could have done anything to mitigate or prevent some of these limitations.
Thank you, highly esteemed opponent, for your compliments and also for your question. The identification of this limitation, especially the one you mentioned, is quite an interesting one. I note that the people that we spoke to at the facilities could probably be in care because they want to take the medication and they are ready to come to the facility anytime they need to refill their medications. And so these people who come to the facility are ready to take their medications. And what I meant by that limitation was that it's possible that those who really don't adhere to their medications don't even show up at the facility. And so given the opportunity, I would also be interested in targeting the people living with HIV who are in the community and don't even show up. But I also understand that the people living with HIV is a very close group, like I mentioned, because of issues of non-disclosure. And so if I have to reach out to people in the community, then I would have to work closely with the HIV peers, who are recognized as the models of hope in the Ghana Health Service. If I work closely with these models of hope, they know people who have HIV and are in the communities. It's important to also note that I attempted to get some of those in the community into some of the focus group discussions that we had. And it was through these models of hope that such people living with HIV could even come and join the interviews that we had. Yes. And in one of their words, one of the words of the person living with HIV who is in the community and not ready to come to the facility, she said that she would rather die than come to the facility and be seen by someone like her in-law. So a person like that and people who have that perception in the community about their fears of coming to their facility are really an important group of people living with HIV that in future I'll be interested in further exploring.
Thank you very much for your response. Indeed, it's always been known that facility-based studies are limited in this way, and the community may be a better place, but you discussed the challenges of finding them quite well. The second thing I found very interesting was the motivation by the people living with HIV/AIDS to continue their ART medication because of visible improvements in their overall health, in spite of side effects and in spite of all these other things that limit their adherence. And the fact that it makes them endure the initial side effects of their medicines because of this. Could you briefly discuss how the health system in Ghana could build on this key finding to improve adherence to ART medication?
The visible improvement in the health of people living with HIV was one of the striking findings of our work. And indeed, it's important that this finding is incorporated in the counseling of people living with HIV. The feeling we had, or the revelations from the persons living with HIV, showed that they would usually report to the facility very late. And so they would start showing overt signs of AIDS. And the transition from their overt signs of AIDS to their current status that they describe was a motivation for them to, continue to take their medication. And in the various health care facilities, the models of hope were also there. And so when they start their medication, through pep talk with these peers, they know that that's a vision, that's where I want to get to. So today I could be like this, but tomorrow I could be like this model of hope if I continue to take my medication. So incorporating the revelation that the visible improvement in their health is something that motivates them to take their medication can be considered in the counseling processes. However, it's very important to highlight that when they show this visible improvement, it does not mean they are cured. And one episode actually happened during the course of this study where a patient who, according to the healthcare providers, had reached viral suppression, but in search of a cure, she left her antiretroviral medication and went to a prayer camp. And the day she came to the facility, it was really sad. So people could also misinterpret the visible improvement in their health as cure for HIV, because at that point, they are showing undetectable viral load. And people who do not understand the dynamics of these things could interpret it as cure. And if they fall prey to it, they would usually come back in worse of situation. Thank you.
Thank you very much. I would pass it on to the rector.
Thank you.
The opposition will be continued by Professor De Rijk, Professor of Work and Health at Maastricht University.
Thank you. Well, also my congratulations with your PhD thesis. You have invested much in collecting data on a topic, as has been said and has been described, surrounded by stigma, and your endeavor to collect all these data deserves special appreciation. Moreover, you also studied the perspectives of the various actors involved, and my question, and it will not come as a surprise to you regarding my background in work and health, will be about one of these groups, the healthcare workers. Thus, I have a question about chapter 3. But first, I would like to answer to have some conceptual clarification, and I have a question about definitions. You have named the respondents in your study in chapter 4 stakeholders. To my opinion, the healthcare workers in chapter 3 are also stakeholders. So can you explain how you define stakeholders and why you did not name the healthcare workers as, or why you did not present them as one of the stakeholder groups in your research?
Thank you, highly esteemed opponents, for your kind words and also for your question. Indeed, I recognize that healthcare providers are important stakeholders in terms of the adherence behavior of people living with HIV. However, in chapter 4, I was relating the stakeholders specifically to the policy implementation. So that's the difference between them. But healthcare providers are also very important stakeholders in this. Yeah.
Well, thank you for this clarification, very clear. We continue with chapter 3, and you show there that individual factors, HRV training factors, and external factors affected the behavior towards people living with HIV. But I missed something that I found very intriguing in chapter 2, because you discussed there that the stigma you found that it might have related to the work pressure and to the fatigue of the healthcare workers. It may be that the high work pressure, the many demands play a role here, and I didn't find a reference to that in the introduction of chapter 3 or in the interview instrument. And in the general discussion of your thesis, you even describe the findings as awkward social interactions in the healthcare setting that were caused by a lack of interaction skills and knowledge on HIV and people living with HIV. But again, work pressure is being neglected. And I found the argument of work pressure in the Ghana healthcare sector and in this setting also with all these numbers of patients very convincing. So, well, can you say a bit more about why this issue is being neglected in chapter 3, and if you would do the research again, would you incorporate some questions about the work pressure, the high demands, and the exhaustion of the healthcare workers that might lead to unkind interactions, rather than that it's a lack of skills?
Yes, indeed. I noted this as well, that and I highlighted also in my presentation about the need for the social interaction skills. That I think it's a combination of factors. It's on one side could be because of their lack of skills, and on one hand, it could also be because of burnout issues or work pressures. I say this because in the healthcare providers' interviews, some of them really alluded to the fact that when they did not have knowledge about HIV, they avoid care for people living with HIV. They either delay to provide the care or go around the patient till their shift is over so that other people can attend to the patient. So indeed, for me, I believe it's a combination of these factors. For some, it could be just the issue of lacking the social interaction skills to deal with people or take care of people living with HIV. But for others, it could also be challenges with having to take care of so many other people at the same time. And if they get tired, they have awkward interactions with the people living with HIV. So it's a combination of these two factors. Mm-hmm. And omitting that in this general discussion is an omission, because for me, the two contribute to this behavior towards people living with HIV. Mm-hmm. Yeah.
Mm-hmm. But what you also say is that your data and collected in chapter 3 was quite convincing in the fact that there was a lack of social interaction skills experienced and expressed, mm-hmm. and also this behavior that then, trying not to take care of this group of patients because of that, and because of that I also read that, and now you explain to me, as if I understand well, that that was very convincing, their statements about that. Mm. Regarding the time, is there time for another question? In chapter 3, you also recommend in the discussion intervention mapping to develop an intervention. I fully understand that you were never able to develop and test this intervention, but of course, when reading your thesis, I started to think about this intervention in more detail. And I wondered whether you would rather make two interventions or distinguish, allow to distinguish within your intervention between healthcare, if you would target healthcare workers. From my perspective, you would. Maybe that's also a question. That if you would target healthcare workers, that you would do it differently in an art clinic and in the more regular clinics, also because of the issues that we just discussed. So can you share some of your thoughts about that?
Yeah, so if I had the opportunity to develop an intervention for healthcare providers, I would do it differently for people living, those in the ART clinic and those in the general healthcare setting. Because as I highlighted in this study, the healthcare providers in the general healthcare setting tend to stigmatize or show negative discriminatory behaviors, whilst those in the ART treated them a bit too special. So the true understanding of how to interact with people living with HIV is quite different, and I believe they will require different interventions to do this. So for people, the healthcare providers in the general healthcare setting, I would target their self-efficacy and skills to, get them to get these necessary skills to work with people living with HIV. And I could do this through modeling, modeling from somebody who is comfortable working with people living with HIV, and also the intervention of, say, guided practice could also help the healthcare providers in the general healthcare setting. And then, in addition to this, they should receive continuous feedback and reinforcement to ensure that their behavior towards people living with HIV encourages them to come to the clinic and also adhere to their medication. On the other side, the healthcare providers in the antiretroviral clinics also, out of, let's say, goodwill, want to treat the people living with HIV a bit too special. And this also sometimes puts them in a position of hopelessness, making them feel like they cannot do anything on their own and they need to be pitied. And when a person living with HIV feels pitied, it also can affect their adherence behavior. So I would also target them differently. Mm-hmm. Yeah.
Well, thank you very much. Very interesting, your thoughts. I will give back the word to the pro-rector.
The opposition will be continued by Dr. Zimmerman, Assistant Professor in Health and Social Psychology at Maastricht University.
Thank you. Dear candidate, also to me it was a real pleasure to read your doctoral thesis, not at the least since I also work in the field of HIV and I visited Ghana for my first research internship about 10 years ago. So it was a pleasure to see that all coming together. The thesis reads very well and describes a very important topic, also as also stressed by the other opponents. As you write in your own words in your thesis, adherence to ART is critical to HIV elimination efforts and results in better health outcomes and a higher quality of life of people living with HIV. So this clearly shows the relevance of your work for both the individual outcomes of the people living with HIV, but also for public health. So congratulations with that. And of course also congratulations to your supervisors. First, I would like to understand the context of HIV in Ghana a bit better. So, of course, you refer a couple of times to these 95, 95, 95 fast-track cities goals. But I was actually unsure a bit about the numbers for Ghana specifically. So in the introduction, you mentioned, for example, that 96% are estimated to be on treatment, but in chapter 2, you described, I think it was only as high as maybe 46%. As for the viral load, so the suppressed viral load, you do mention numbers related to the adherence of about 70%, but nothing about viral load. And I also couldn't find numbers for the first 95, so the number of people who've actually been diagnosed. So can you elaborate on a bit about that to make me understand the context a bit better? So how should I look at the 95, 95, 95 goals for Ghana?
Thank you very much for esteemed opponents for your question and also for your kind words. Indeed, the focus of our work was on the last two 90s. So at the time of this work, we were working with the 1990 goals that have grown to 95 goals that we are working on now. And I did not really mention the first 90 because the focus, like I said, were on the two 90s. But as at now, for the 1990, at the end of 2020, Ghana scored 58, 78, 68. And so it's well below the 1990 targets that we were hoping to achieve. And because we were not able to achieve this 90, the barriers to the not reaching the targets as was expected, some of the findings from this study are feeding into it. And I see a lot more things happening in the media space related to the shortfall in the achievement of these targets. Yeah, so that's kind of the reflection of where we are, where we were with the first 90, and working towards reaching 95. Yeah.
Thank you for the clarification. Then I'd also like to ask a bit about the design of the intervention, as also the previous opponent, but I have a few different, probably related, but different questions. So of course you refer a couple of times to the need to design this intervention by, for example, the use of the intervention mapping framework. I was wondering, based on your results, what would be the focus? So for example, what would be the behavioral outcome that you would focus on?
Yes, so generally in the needs assessment that we did, I note three people that we could target in this study. So the healthcare providers are one group, the people living with HIV are also another group, and the policy stakeholders is another group. And if I was developing an intervention, I would go for the healthcare providers, because I believe that they sit in the middle of the policy and also the field. And the differences that they could make at that level could influence the adherence behavior and their implementation of the policy from the policy stakeholders that were identified would also speak to achieving the policy outcomes. The objective that I would target would be, because I'm talking about issues of self-efficacy and skills, I would concentrate on the change objective of getting the health workers to express confidence in taking care of persons living with HIV. That's the kind of change objective that I'll be working with. And then the individual beliefs in this self-efficacy I can work with to design an intervention to improve antiretroviral adherence among people living with HIV in Ghana.
So I would agree that the healthcare providers are a very important, I think, target population to target in an intervention. And I also agree that it might not be the people living with HIV, at least the ones that you researched in your thesis themselves, since it seems they are very well capable, actually, of adhering. But it's more the interaction with the environment, so what limits them from maybe adhering to ART. But maybe not only with healthcare providers, but also in the community surrounding them. So besides the policymakers maybe and the healthcare providers, what would you do, for example, with the community members surrounding them?
Great. From the community's perspective, it's a good, they are good environment, that you note, that influence the adherence behavior of people living with HIV, and even in the understanding of the healthcare providers as well. Because I believe that whatever the people living with HIV and healthcare providers believe, their perceptions about HIV and how they relate to issues about HIV are shaped by the community in which they live. And so the community could also be an important avenue to increase awareness and reduce some stereotypes about HIV and issues related to it. Yeah.
All right, thank you. I have another question. So if you talk about this medication adherence, you introduce it sometimes with stages, so the initiation of ART, the implementation of ART, and the persistence relating to the length. I don't see it coming back very much in your findings, though. So you treat medication adherence as basically one thing without the distinction between these three stages. I don't know if you call them that. So would you say that are the different factors important for each of these stages, or are all the factors that you found important for all of these stages?
I believe that there would be different factors at each stage. For instance, at the initiation stage, if a person living with HIV does not come to a clear understanding of possible side effects of their medication, they could just stop there. And then if they overcome the issues of the initiation, overcome side effects, and persist to take, implement their therapy, they could also be influenced in the course of implementation by their significant others. And that also, for me, I believe, have different determinants at that point. If they are persisting, meaning that they are staying on this medication for the rest of their lives. And it also would require some other determinants that will make them want to stay really on their medications for the rest of their lives. So you are right, it did not really come through the rest of the thesis, but actually I believe that for each stage, different determinants may overlap and then differ at some point.
Yeah. So if that's the case, would you focus then your intervention on any of these stages specifically, and how would you do that?
I would look at the issue of persistence. I would concentrate on issues of persistence because that is where we achieve the viral suppression. Because if the person living with HIV starts and does not complete, it goes into other issues of issues about being resistant to the medication. That is a problem for the health system and also for the person living with HIV. For instance, if they are resistant on the first line, it means that they have to be moved on to the second line, which is more expensive, to the healthcare system and also probably for the patient. So I would rather concentrate on the end goal. Once you initiate, I would expect that you get to the point of viral suppression, and that is where your overall health will be improved, your quality of life would improve.
Thank you.
Marta Abdulai, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
south side. 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Marta Abdulai. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdicts and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Ruiter is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor now to take the floor.
Dear candidate, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I do.
Thank you. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Marta Ali Abdulai, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree of certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Give it a try without reading glasses, but I have them there, just in case. So, Marta, there you are. I wonder what you feared most, your defense or my laudatio, about which I've teased you so many times. Everything you do or tell me during your PhD tract can be used against you on the big day. But don't worry, you know me better than that. I'm very, very proud of you. You did it. You are Dr. Marta Abdulai from now on. And what an adventure it has been. It started in 2016, if I remember well. You contacted me via John Kruger to inform about the options of doing a PhD at Maastricht University on HIV stigma and treatment adherence under my supervision. I invited you to write a research proposal, which we could then discuss. Your proposal convinced me of your qualities and your potentials for doing a PhD. The first big step we had to take was trying to get funding for your project. We decided to apply for a NUFIC grant, and we asked Arjan to join, considering his expertise on stigma research. And altogether, we managed. We got the grant. So the PhD project could start in 2017. During the time we worked together, I got to know you as a hard-working woman who does not shy away from challenges. A characteristic that is very nice to work with for a supervisor, especially one like me. I remember several times to provide you with different options on how to go about the study, telling you the pros and cons of each option. And you never decided to select the most easy option, if that was going to provide the most optimal result for the study. For example, the longitudinal study, the last chapter, you could have decided to not include all the different behavioral measures, the MEMS gap, the pill count, and you could have decided to only collect data from a few hospitals close to where you live. That would have made your life much easier. But no, you wanted to get as close as possible to the best design and the most interesting results. Little break. So it became a longitudinal design, including 3 different measures for behavior, I think more than 20 determinants measured at 4 time points, and a sample size of about 750 people. For any PhD project, that would have been a huge study and a huge challenge. But for an external PhD working in the complicated circumstances like you did, it really is a big achievement. So you should be very proud on yourself. And there have been more challenges during your project. A diverse set of studies focusing on different target groups, different behaviors. It asked a lot of your writing capacities, but also personal circumstances. They were tough. Living very far away from your partner, not being able to fulfill a family dream that you both wanted so much, a close friend passing away, doing part of your PhD next to having a research position, a full-time job, and having your supervisors about 7,000 kilometers far away. I used Google Maps to calculate that. And then also working in different time zones, a confusion that kept interfering with our meetings, summertime, wintertime. And then on top of it all, the corona pandemic, which suddenly made traveling very difficult, and the supervising chasing positions. But you have dealt with all the challenges and you kept going, and now today we see the end result of your own resilience. While reflecting on the past years as your supervisor, also some funny moments came back. Like the time you came to the Netherlands and you had to bring all the 250 MEMS with you back home to Ghana, because we didn't dare to send them by post. I think Frank came all the way with some additional suitcases to put in all the MEMS caps, and Rob and I wrote some letters that we signed so you could easily pass the douaniers, so they would not blame you from carrying Dutch drugs back to Ghana. And also one day in Kentampo, I wanted to look for fabrics, and I convinced you to go by feet because that was healthy, but I forgot about the extreme heat midday in Ghana, and I think we walked for more than an hour. We were totally exhausted and dehydrated, and I felt very guilty. And of course, the great trip to the monkey sanctuary, in which you convinced me and Frank that you exactly know how to get there. It's due to his excellent driving skills that we did not end up upside down in a ditch. I have to tell you, we in the end arrived there. It was all a great adventure and experience also for me. And it would not have been possible without the support of especially Arjan, but also Rob, and of course the time and support from the director of KHRC, Dr. Asante, and OE, and the management and staff. And last but not least, the master students from Maastricht University, Veerle, Annika, and Zoe, who helped in data collection. So now it's time to relax. And we can maybe finally make the trip to Hawaii if there's a bit of money left on the Nuvik rent. You deserve it. Congrats first and foremost for yourself, but also for your partner, your family, your colleagues, and your friends. You should be proud, and I hope you will now take some time to relax and celebrate.
Thank you.
Dear Dr. Abdulai, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. And then we are now at the end of this academic ceremony. And normally we also ask the visitors to already go to the room where the celebration will be, but there are so few of you that we can just stay here and take pictures. The session is closed.
Dr. Asante, if you put your camera